I'm Dr. Timothy Clossie, professor of neurology and director of the neuro-oncology program at UCLA Medical Center in Los Angeles.
I'm Dr. Giuseppe Lombardi, a medical oncologist at Veneto Institute of Oncology in Padua, Italy.
Welcome to this segment on emerging therapies in malignant glioblastoma. In this chapter, we'll review and discuss data from clinical trials of the NTRK inhibitors in glioblastoma with regard to the intracranial response and some information with regard to the durability of response. We'll also talk about some of the ongoing or upcoming clinical trials and then future directions in glioblastoma. One of the interesting findings at the most recent ASCO meeting, there was some data on patients with glioblastoma who had received this NTRK inhibitor, larotrectinib. All patients had the NTRK fusions. At this point, there were up to around 20 to 30 patients who were treated, and the response rate was somewhere around 36%. The durability of response is still ongoing for many of them, and many of these changes occurred over a fairly rapid period of time. Some of the best responders have been lasting up to 13, 14 months, and again, many of them still ongoing. So this is really an impressive finding because this is not what we typically see with any targeted therapy in glioblastoma. So this really identifies a unique opportunity for us in this field.
Entrectinib is another very interesting molecule, and it's a pan-NTRK ROS1 and ALK inhibitor, and is a CNS penetrant drug showing important intracranial activity in CNS metastases from various types of tumors, in particular lung cancer and colorectal cancer, as we saw from Star Trek 1 and 2 trials. Among evaluable patients in this trial, we had about 63% of intracranial response, and at ASCO this year will be presented a very interesting trial about primary brain tumors in children and adolescent patients with high-grade gliomas treated with entrectinib. Among 5 evaluable patients, we have 1 complete response and 3 partial response with a prolonged response with a median the duration of treatment of 281 days. In a Star Trek 1 trial, we had 1 patient with glioneural tumor have a partial response with a maximum reduction of 60% and a treatment duration of 11 months. In general, entrectinib is a well-tolerated treatment and with predominantly grade 1-2 adverse events that were reversible with those modifications. Rare grade 3 adverse events were diarrhea, arthralgia, and weight increase. Another very interesting drug is regorafenib. Regorafenib is a multi-tyrosine kinase inhibitor. It was analyzed in a REGOMA trial, a multi-center randomized phase 2 trial, analyzing relapsed glioblastoma. We had an overall response rate of 5%, but important disease control rate of 44%. In this trial, regorafenib was compared to lomustine, and we had a longer overall survival in regorafenib group compared to lomustine. The 12-month overall survival rate was 38.9% with a significant hazard ratio of 0.50. The median overall survival was 7.4 months, and the 6-month progression-free survival rate was 16.9%. Common grade 3-4 adverse events were handful skin reaction in about 10% of patients, and the lipase increased and the bilirubin increased in other 10% of patients. At ASCO this year, we presented data on quality of life, and we demonstrated that quality of life did not change during regorafenib treatment, and the patient treated with regorafenib and lomustine reported no significant difference in quality of life.
So there are some other drugs that have been evaluated in the past that are the multiple tyrosine kinase inhibitors. And again, as I said before, they get split out into those that have a real impact on the blood-brain barrier and decrease edema and contrast. And there are those others that don't, more along the line of regorafenib, that has maybe a little bit less VEGFR2. And so in the past, we have evaluated two, I think in particular. One was cediranib, that went through randomized evaluations with or without CCNU, did not show a statistically significant survival benefit. One of the other evaluations was with cabozantinib. And with cabozantinib, these were mostly a single-arm phase 2 study, even though there was a fairly high number of patients, 152. Again, the response rate was on the high side, almost 18%. The 6-month progression-free survival between 22% and 27%. And the overall survival between 7.7% and 10.4%. This was a larger trial that required 2 different drugs that were evaluated. This has not moved forward into a larger setting. Some of the other multikinase inhibitors that were used have less of an impact on VEGFR2. Those are somewhat similar to regorafenib in that way. Those include sunitinib as well as sorafenib. And in those settings, they were single-arm evaluations that took place and not a randomized evaluation. So those never moved forward, and we don't really have a good understanding of what the impact could be, as well as we do with regorafenib. So there are other trials that have been ongoing in our field, and we've had a couple of disappointments, of course, recently. But immunotherapy is a big part of what we would like to be involved in. And there have been a couple of large phase 3 randomized trials using nivolumab that's been used in the recurrent setting and then recently reported in the unmethylated setting. And in both of those large phase 3 randomized trials, they were negative studies. We've also had some evaluations with pembrolizumab, but these have been fairly limited, mostly in recurrent setting, mostly single-arm evaluations, so it's less clear. I will say we're still waiting for the outcome of the nivolumab study, where MGMT is methylated, and that will be a separate phase 3 study that's going forward. But you have an interesting study that you're involved with.
Yeah, we presented at ASCO this year a study analyzing pembrolizumab in a particular subgroup of patients having the mismatch repair deficiency. We performed this study focused on this biomarker with the possibility to have a longer survival and a great benefit from this treatment. The results showed that we had about 33% of patients having a stable and a prolonged disease. And maybe it could be a biomarker, but further investigation will be studied.
There's some other approaches that are non-immune therapy. Wondering if you could touch base on that.
Other interesting trials with future directions could be veliparib. It's a PERP inhibitors showing promising preclinical results in association with temozolomide. First or second line patients is ongoing, and it will be very important to understand which patient could be responsive to this treatment. And another interesting trial was the Interlance 1 and 2 analyzing the ABT414. It is a conjugate antibody, target EGFR when amplified, and unfortunately, the Interlance 1 reported negative results, and about Interlance 2, it was a trend for longer overall survival in recurrent glioblastoma. Other interesting treatment or with other mechanisms as viruses.
Yeah, so there has been a lot of movement in our field with viruses, and whether this mechanism is a immune therapy or gene transfer. There's a phase 3 study that we're waiting to hear about from TOCA 511. DNAtrix is moving forward with a trial and a phase 2 trial. The polio virus has gotten a lot of attention from some of the results that came out in a phase or a single arm evaluation. VB111 is another intravenous dosing virus. There have been a lot of these. They're interesting. We'll see how they turn out. It would be really helpful in our field if we saw some benefits there. You know, one of the other areas that we're trying to do is to evaluate multiple therapies at the same time and to try to set up these platform trials. And there's been a number of different environments where that's taken place. And the nice thing about it is you have a single control and multiple therapies, so you can evaluate them at the same time. There are two that are doing these as kind of a screening test, so randomized in the end against the control. That's the M2N2 that's coming out of Germany, and also Insight that's taking place at Dana-Farber. The final one is GBM Agile, but this is looking for a registration quality approach where it takes you through a screening phase and then a confirmatory phase, and then at that confirmatory phase, one could move forward with a new drug application. So, you know, it seems pretty exciting. We have a lot of new things that are going on. We hope that we'll be able to move forward in this field with many of these other approaches.
So, in conclusion, glioblastoma remains an aggressive disease leading to a deterioration in quality of life, and its prognosis still is poor. So we need new drugs.
And one of the other interesting things is we're finally able to take advantage of some of the molecular characterization that we're coming out with, not only with the NTRK inhibitors, but also IDH inhibitors, and then the example that you have of hypermutation or using in the immune therapy setting. We have a long way to go with immune therapy, and it's very promising, but there's other approaches such as DNA damaging response inhibitors that I think are beginning to show a lot of promise as well. So at this point, we just want to thank you all for participating in this study. I'd like to thank Dr. Lombardi for taking part in this with me.
Thank you, Professor Clogsy, for his participation in this interesting meeting, for your consideration.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.